International Journal of Health Policy and Management. Quality and speed are our culture and the keys to our success. Welcome to the audio summary section of the International Journal of Health Policy and Management.
Good afternoon. My name is Bartholomew Armah, and I am the chief of the planning section, which is part of the macro policy division of the UN Economic Commission for Africa. My article, titled Sustaining Health for Wealth, Perspectives for the Post-2015 Development Agenda, is a commentary on an article by Binangwaho and others. In their article, they identify a number of principles that should guide the post-2015 development agenda going forward. Two of these principles focus on inequality in access to health services and the need for a more integrated approach to health delivery. My article takes this article or their position a little bit further by embedding it in the whole process or the whole issue of sustainable financing for the post-2015 development agenda. The premise is that sustainability requires improving equality or equity in access to health services, and also implies a more sustainable financing mechanism for health going forward. African countries have relied on ODA, particularly vertical funds, for the funding of a number of key high-profile diseases such as malaria, TB, and HIV, and this has yielded some success. The question is, how do we sustain the success going forward? Let me recap by recounting how Africa has gotten to this process, to this level so far, and how we can move forward. At the beginning of the 1990s, the health indicators in Africa were relatively poor compared to other regions. However, a remarkable progress has been made, even though Africa will not achieve the MDGs, particularly in terms of the health indicators. Nevertheless, in terms of under 5 mortality, the decline has been 55% between 1990 and 2014. And infant mortality has declined 40% over the same period. HIV prevalence rates have declined from 5.6 to 4.7% between 2005 and 2013. Malaria cases and deaths have declined at a much steeper rate than the global average. And Morocco and Egypt have virtually eliminated malaria. These achievements are no small feat, once again in the context of the initial conditions that were relatively low in Africa, and must be commended. But the important question then is, how can we sustain this progress? How can we ensure that it's sustained over time and sustainable over time? Particularly when we take into account the fact that the global economic recovery has been sluggish, the sovereign debt crisis in Europe continues, and ODA to LDCs declined in 2014 by 16% in real terms. So the very source of financing for these high-profile diseases is questionable, and therefore we need to re-strategize in terms of how we ensure that progress going forward is not crippled by this lack of resources. What we need to do, in my mind, is first to address issues of inequality, and second to address issues of financing to ensure that it's more sustainable. In terms of inequality, what is required is addressing the spatial, gender, and income inequalities that persist in terms of access to health services in Africa. A number of statistics will probably throw this into more perspective, into greater perspective. At the spatial level, in terms of spatial inequalities, rural-urban inequalities are manifested by relatively lower access of rural dwellers to skilled birth attendants. 42% of rural areas rural births are attended by a skilled health worker compared to 77% in urban areas. But even within urban areas, there is a divide between those who live in slum areas and those who live in relatively more affluent areas. 40 to 70% of Africans live in slum areas and have relatively lower access to health services than those who live in more affluent parts of urban areas. Income inequality is also a barrier to access to health services. 85% of households in the highest income bracket compared to 31% in the lowest income bracket have access to skilled birth attendants. Now, how do we address this? Improving access to social protection is critical. Improving access to employment through a more inclusive growth process that not only focuses on producing and exporting raw materials, but adding value to these raw materials not only increases the returns to those investments, but also increases the scope and breadth of society that is involved in the production and hence the incomes that are generated and from the sale of these products. Improving the rural areas, investing in rural communities, agriculture, rural transformation is also critical to ensure a more inclusive growth process. Now, the second area that I'd like to discuss is how we ensure that our health expenditures maximize the returns in terms of impact. First is to identify interventions that have the greatest knock-on effects in terms of the impact on other health indicators. Let me give an example. Investing in midwives has been estimated to yield a 16-fold return on investments by reducing the incidence of cesarean sections. Ethiopia's community health scheme, for example, contributed to a 40% reduction in infant and maternal deaths. Antiretroviral treatments given to TB-free HIV patients reduces their chances of contracting TB by 66%. Within this context, there's another area which is really strengthening health systems. And in this context, I'd like to draw attention to the positive role that vertical funds have played so far in terms of reducing malaria, TB, and HIV. But if we are to ensure a more sustainable impact of our expenditures, we need to go beyond vertical funding to a more horizontal approach that takes into account strengthening the health system in general. Indeed, the Ebola crisis has really laid bare the challenges that health systems face in African countries, and the fact that a single disease can wipe out the gains that have been generated by the vertical funds. Vertical funding has not paid sufficient attention to strengthening the healthcare system in Africa. For example, cumulatively, global fund spending on health systems accounted for a mere 2.5% of the total during the period 2002 and 2013. Hence, there's a need to focus more on this area. Indeed, there is no evidence to suggest that individuals or communities that benefited from global funds were more resilient to Ebola than non-beneficiaries. The third area that I'd like to focus on is mobilizing domestic resources to improve health financing. ODA has played an important role here, but now is the time to complement ODA with a more robust and aggressive domestic resource mobilization effort to ensure that health financing is not held hostage to vicissitudes in ODA or unpredictable ODA access. And why is ODA likely to be more unpredictable in the future? The sluggish global recovery and recent declines in ODA to LDCs render ODA unpredictable. Commitments for the health sector in terms of ODA have decreased despite continued increases in disbursements. And at the domestic level, African countries still fall short of the Abuja Declaration target of 15% of spending 15% of resources, 50% of GDP on health sector financing. Indeed, per capita spending on health in Africa averages around $10 per person and ranges from a low of about 47 cents to a high of $341. 32 governments in Africa spend less than $33 per capita on health, which is well below the recommended minimum of $44. In conclusion, African governments have made remarkable progress on health indicators despite low initial conditions. External funding, especially for HIV, TB, and malaria, have been vital for success. However, sustaining the progress made so far will require addressing spatial, gender, and income inequalities in access to health services, a more strategic approach to health spending, and a more robust domestic resource mobilization effort to boost health spending. I thank you for your attention.